Hello, everyone. Hopefully no one's having any technical difficulties and they can hear me. If not, feel free to drop it in chat or you can private message me or whatever you feel comfortable in doing. You can also message one of the co-hosts as well. Um, that also works. I'm just going to start off and say welcome everyone to our live session today. This is pre-health shadowing. Hopefully you're in the right spot. I'd be surprised if you weren't. It was very hard to get this link if you are not registered. I just wanted to go over a quick presentation and then I'll welcome Miss Whitaker or Dr. Whitaker to our session and she'll have her slides up in a minute. So we are an international student-led and minority-led nonprofit centered around medical advancement and having people have the opportunity for more resources and giving you guys kind of a look into the medical field and all of these different professions in pre-health. So we do have closed captioning, just a little PSA just to get started. If you do have any questions about that, or if you even have any ideas on how we could be more accessible, we are very happy to hear those at info@prehealthshadowing.com. You can save us as a contact so we don't ever spam you. Our emails are only going to pertain to these sessions or replies to you. So you will not get bombarded with random marketing things or anything like that. So you're welcome to add us as a contact so that you get those updates. And if you have any ideas or if there's something that we can help you with for this session, feel free to email us. We do have the closed captions. It's through Zoom, so it's a button on wherever you have your task bar should have closed captioning. If you don't, we're also more than welcome to provide you with a transcript if you email us or if you message in chat. Just so you know, I see a lot of people getting in. We do prefer that you mute yourself. I'm just going to throw that out there now, but so that you don't distract from anything that I'm saying or anything that Dr. Whitaker is saying as well. So that being said, if you want to stay in our loop, we do have Instagram, TikTok, Twitter, we have LinkedIn, and we have YouTube, all of which are updated daily, weekly, monthly with all of our sessions, as well as any information on our program. We do sometimes have reviews or people's comments, or sometimes, and at the end of it, I'll talk a little bit more about how you can get published or posted on our LinkedIn. So if you want to stay and listen to that'd be great. And also I'll go over the quiz and everything like that as well. So we do host people from all over the world, and we always ask where everyone's coming from. I am in Los Angeles, and I know our professionals in Texas. So if anyone wants to drop in the chat where they're calling from, I'll call you out. We have had people from all over the world, which is always nice, but most of the time it's the East Coasters. No, not many West Coasters over here. Maybe it's the time zone thing, but it is early. New Jersey, okay, East Coaster. California, Texas. Oh, this Western. Alabama, Illinois. Oh, another California. California's taking over. Oh, there's a couple other Texas people. New Jersey. Okay, so we have all over the United States. I don't think we have anyone from Massachusetts. You know, I always spell Massachusetts wrong also, just quick little tidbit, but let's keep going. So we do have a volunteer aspect to our program. It's pre-health shadowing. If you go to our website, there is next to shadowing is get involved, and you can look through how to get involved. We have a few different ways. It depends on where you are in your education. If you're a high school student, I will be sharing a little bit more information in upcoming slides about that. But if you are pre-health or you're an undergrad, we do have volunteering through our website that is 100% remote. So if you want to join that and kind of be a bigger part of what we're doing here and support us, then we'd love for you to join our network. And you can be a part of just the volunteering team, or you can also apply to join our leadership team. Those include various different roles. And that is also 100% remote, but it is a few more hours during the week. Here's the available roles. Additionally, if you see something that maybe you have a skill set for that's not listed here, you can also make your own role. And you can propose that to our team and see if that's something that we would be happy to include or create for you. We're always welcome to see whatever other skills that people provide. And some people come up with their own unique roles that have shaped who we are as a program. So I'd love to hear some of your ideas. If you want to email us, or if you want to go to the website, you want to apply, you can meet the team and you can kind of share what you were thinking and how you can improve our website or our program or how these sessions are run, anything in that regard. So I did mention a little earlier, if you're a high school student, we do have a high school training program, HTP. It's a leadership and healthcare education program for pre-health or pre-college students. So that's primarily in high school. I know that there are some ways to get information on making, say, a club at your school or your college, and that would be more college-based. But for high school, we do have a program, a training program to help you set up a program or a club at your school that would kind of interact with pre-health shadowing, and we have full training on that. And we're also very happy to mentor and guide any students that want to do that. So if that is you, you can go on our website. I think the link is in the chat as well. If you are in this live session and you want to go look at that right now, you're more than welcome to. You can also look at that and save that for later tonight or later today. But if you don't want to do that, and then feel free to, no problem, just don't click that. But we do have different various opportunities on our website if you want to go and get involved later after this session. So part of our mission is to promote diversity. And in order to do this, we've launched an initiative and we've been trying to get this more up and coming, is to make future panels to have highlight important topics, say in the LGBTQ plus or sexism or racism or racial disparities in medical fields and healthcare. And so if you have someone that has inspired you in this key diversity initiative, then you're more than welcome to email us their name or their contact, and we'd love to set up a panel, maybe have a few people that have been inspiring, and have more of a chat about how diversity is changing the healthcare field. I know that there are various different things that are going on and that are changing how we are educating and learning about diversity in healthcare and how that is impacting further healthcare in changing people's lives. So if you have someone that's inspired you, feel free to nominate them. We're always loving and happy to have someone around like that. So last but not least, I do have a few more things, but if you can donate, that'd be great. There's a QR code, but there's also on our website, you can go and they have more information on the donations. We do also have different programs that you can donate to. We are in the initial steps of publishing a book. That would be amazing to have more people donate to or support. So if you can't donate money, you can always donate time. We do run solely off time and donations. And while these sessions are free to everyone that participates in them, they aren't free to host or to keep everything up and running, such as the website and all of our information and our technical aspects of this site. So if you can donate, even if it's a few dollars, that'd be great. If you can't, no worries, don't worry about it. And you can always look into donating some of your time. We'll continue. So we do have a Q&A at the end. It's about 20 minutes, maybe 40 minutes, depends on how long our timing goes. We will be ending our session at about an hour and a half. So around 5 o'clock will be the end of our session today. So if you have any questions, feel free to type them in the chat. We will be noting them down. So don't worry about your question kind of going off into the wind. We will have that written down and we can ask it at the end for you. Yeah, alternatively, if you want to ask your question yourself, you can always raise your hand and I will call on people to unmute and you can ask questions directly to Dr. Whitaker. I'm sure she's happy to talk to you about any questions you have about med school or the med school journey or about pediatric emergency medicine. Any of those topics can go into that chat. So take good notes. Our post-shadowing assessment will be available at the end of this, and you can earn a certificate verifying your hours on the professionals course page. That's the same page that led you to this Zoom link. So you're welcome to go back to that page and take the assessment afterwards. I'll have a little presentation explaining how that works and how everything should run for that so that you guys can understand the best on how to do that so you don't make any mistakes or have any errors in that. So lastly, turn your cameras on. We always love to see people's faces, and it's not a face-to-face environment being on Zoom or on any kind of video recording. So if you can share your face, we'd love to see your face. If you can't or you don't want to, don't worry, no problem. And I'm gonna welcome Dr. Whitaker, and I hope everyone enjoys her presentation, and I'll see you back for the Q&A.
Hey everybody, thanks for inviting me. I'm glad to be here and just kind of give you a little snapshot of how I got to where I am and what pediatric emergency medicine as a career looks like. I have got some slides here. Let me share my screen. Okay, can everybody see that okay? Yes, perfect. Okay. So, like I mentioned, I'll kind of go through my background on how I ended up where I am, and then we'll do a little overview of pediatric emergency medicine as a profession, and then we'll have time for questions and answers at the end. So, I was born in New York, grew up there, and then ended up going to the University of Pennsylvania for my undergrad. And when I went, I really had no idea what I wanted to study or ultimately do in life, was not necessarily focused on pre-med as I went in. And so I took some core classes. I happened to take a couple of anthropology classes, really loved it, decided to major in it. And through that, I did take a medical anthropology class and decided to get a concentration in human biology. And that really kind of spurred my interest in potentially doing medicine. And so started taking the prereqs for that, ended up with a minor in chemistry. And I was lucky enough to be a Benjamin Franklin Scholar while I was there. So that let me have some smaller classes and really get to know my other classmates and professors. And that was a great experience. And for part of my time there, I think probably my sophomore through senior years, as I was thinking more pre-med, I got a job in a cell biology lab. And initially, I was just making fruit fly media for the lab, just as the lab assistant, and then stayed on a summer to help with some research, and then continued as a research assistant until I graduated. And during that time I was in college, my family actually moved to Texas. My dad was an engineer with IBM and decided to move to Austin. And so, fortunately for me, that meant I was eligible for in-state status as a Texas resident. And there were a lot of great schools available to me in Texas, and they were much more affordable than the schools I could have attended in New York. So I ended up doing medical school in San Antonio. At the time, it was called the University of Texas Health Science Center in San Antonio. It's now the Long School of Medicine. And so I went straight through, did not take a gap year like many students do now. And again, at the time, very traditional model. So first 2 years in the classroom setting with didactic courses, and then your last 2 years are your clinical years. And I did some away rotations during my fourth year of medical school, which a lot of students do. And I highly recommend it if you're interested in specific parts of the country, or you're just kind of putting out feelers because you're not sure where you want to end up The one thing you want to remember though is, for that duration of your visit, doing your rotation, whether it's 2 weeks, 4 weeks, 8 weeks, whatever it is, just know it's basically, a 4 week long interview. So it could go really well and go in your favor, or it could go really poorly and actually hurt your chances of getting into that program. So just something to consider as you look into those. But I actually did 2 months in Cincinnati because I was dating someone who was a year ahead of me in medical school. And so he had matched to a program in Cincinnati. So for me, if I wanted to end up in the same place, I really wanted to show interest and get to know the people in the program. So I did 2 months there, which was a great experience. And I was lucky enough to match there for my pediatrics residency. So pediatrics is a 3-year residency. So I was at Cincinnati Children's Hospital Medical Center for all 3 years. And a lot of different tracks that you can take when you go into residency. Some people, like me, were straight pediatrics, but there are other alternatives like pediatrics genetics, pediatrics / neurology, pediatrics. There's a triple board. So you, at the end of your residency, you'd be boarded in pediatrics, psychiatry, and child psychiatry. So different permutations that you can do. So I also did an away rotation in my second year to one of the U.S. Commonwealths in the Northern Mariana Islands, which was great. So I spent a month in Saipan, which is over by Guam. And that was kind of when I really solidified my decision to do a PEM fellowship. So I was sort of late to the process. And the applications are due early in your 3rd year. So there was time for that. I did have my first child towards the end of my 3rd year of residency. So that, brought some of its own challenges in terms of applying for fellowships and timing and things like that. But luckily, I was able to take 12 weeks off of maternity leave, and Cincinnati Children's was really supportive for that. That was pretty much the norm for most folks in training who had babies. And so we got 12 weeks off, but you just made up that 12 weeks when you came back. So I graduated a little bit off cycle, but it was not an issue. So once you finish your pediatrics residency, then you take the certification exam, which is offered every fall. So most people graduate in June, and then you take the pediatrics board exam in October. So I was off cycle, so I finished in September, but still took the boards in October. And then residencies all look a little bit different depending on where you go, but this is just a little blurb for the pediatrics residency here in Austin, Texas, kind of what their basic required rotations are. And this is pretty standard across the board, no matter where you train. So all pediatric residents get training in the emergency department. How much time you spend there really kind of varies, but typically it's anywhere from 3 months to 6 months. And you do quite a few months of inpatient wards. Everyone rotates through the newborn nursery. You also rotate through the neonatal intensive care unit. And again, how many months you rotate through there will vary. And then you rotate through the pediatric intensive care unit, so older children. And then quite a few subspecialty and other professional development electives. And there is a fairly sizable ambulatory component too, because not everybody who trains in pediatrics is going to subspecialize or do inpatient medicine. Many of them want to do outpatient clinics, more ambulatory medicine. So quite a bit of time is spent in continuity clinics, and there's an adolescent medicine rotation, and then all residents also rotate through developmental and behavioral pediatrics. And many of the residents, as part of their electives, will choose other outpatient experiences too. And then once you finish residency, like I mentioned, you can choose to practice general pediatrics, or you can choose to further subspecialize and do a pediatric fellowship. So this is the current list of pediatric fellowships through the American Board of Pediatrics. So pretty wide range of topics. So adolescent medicine, cardiology, child abuse, critical care, developmental pediatrics, emergency medicine, which is what I did, endocrinology, gastroenterology, hematology, oncology. So there's a whole bunch. There are 5 on this list that have the little asterisk. So those just mean that these are fellowships that you get board certified by the American Board of Pediatrics, but also by another board. And then the last 2, academic general pediatrics and urgent care, are a little bit different because those are just 1-year programs. The other programs typically, for the most part, are 3 years. Some of them are 2 years. So pediatric emergency medicine is interesting because if you do a pediatrics residency and then you go on to do a PEM fellowship, it's 3 years for your pediatric residency and 3 years for your PEM fellowship. So it's a total of 6 years of training after medical school. If you come from an emergency medicine residency, those are typically 3 or 4 years in duration. And you can also pursue a PEM fellowship after an emergency medicine residency. And so fellowship for the EM trained residents is either 2 years or 3 years. It has to be at least 2 years. And so our program here in Austin offers it as a 2-year program for the EM trained residents. Some programs will still require a full 3 years just to keep it consistent for all of their fellow classes that they have. So again, I did my fellowship in pediatric emergency medicine, and it was kind of a tough decision on where to apply and where we ended up. So it's a matching process, just like residency is. So you interview, you submit your list of places in the order of your preference, and then all the programs submit their rank list of applicants too, and then you get matched to your highest program that you ranked, who also ranked you highly. And, you know, at the end of the day, I chose Cincinnati as my top choice for a couple of reasons. One, it's a phenomenal institution. If you guys aren't familiar with it, it is, you know, world renowned for so many specialties, and kids fly in from all over the world for care. And it is one of the top programs for pediatric emergency medicine training specifically. So it was kind of hard to leave when I knew I was going to get great education and already kind of had some roots set there. And, you know, the other thing too was, like I had mentioned, you know, I had a baby that was born right before I graduated my residency, and just trying to figure out sort of ease of life and just cost of living, things like that. We ended up just staying in Cincinnati for that. And it was a great decision for us. You know, my husband was a year ahead of me in training. So he had graduated and was in private practice and was loving it and very successful. And so it was nice not to uproot him from his position as well. So I stayed in Cincinnati for my fellowship training, and started off cycle 3 months late, which was not a big deal. And the way fellowships work, you have a clinical requirement, and then you typically have a research requirement as well. So each fellowship type does it a little bit differently. So some are 1 clinical year and 2 research years. For emergency medicine, it's a highly clinical specialty. So we're the opposite. So we have 2 clinical years and 1 research year. And then I had a second baby, my 3rd year of fellowship. So the 2 kids were 3.5 years apart. And again, I took my 12 weeks of maternity leave, came back, and then graduated off cycle. And again, they were fantastic about it. Everybody did it. So it was not a big deal to graduate late. So I ended up finishing fellowship 6 months late. So when you finish fellowship, so because there are not as many people who do fellowships and who have to sit for their board exams, they don't offer the certification exams for the fellowship subspecialties every year. They're offered every other year, and the specialties just kind of rotate which ones are even years and which ones are odd years. So my boards actually were about a year and a half, almost 2 years after I graduated, because I graduated on an off year. And I ended up staying in Cincinnati after I finished my fellowship as an attending physician. And so, and again, a lot of that decision was because of the resources that were there. Now we had 2 kids to think of. We had childcare established, which was phenomenal because Cincinnati Children's had a daycare on site. And so it just gave us so much reassurance that the kids were in great hands. And then again, my husband was in private practice and pretty settled. So it was a hard decision because we don't have family in the area, but at the time it was the right thing to do. And so at Cincinnati, when I signed on, everyone basically had the same contract or offer. So we were expected to do about 26 clinical hours a week. So typically about 3 to 4 shifts a week. And Cincinnati has a really large training program for pediatrics and for emergency medicine, so that we always had tons of extra help in the emergency department. So most of the patients who came through the ED were seen first either by a resident or a fellow, and the attendings were really just kind of there to supervise. So we would go in and see every patient, but we weren't starting, every workup from beginning to end. And so we had 8-hour shifts, and these were the 4 shifts that were in place when I was there. We had a day shift that was 8 to 4. We had a mid shift or evening shift that was 4 p to midnight. We had an overnight shift, which was midnight to 8 a.m. And then we had a short overnight shift to kind of help clean up all those evening volumes. That was just a 4-hour shift from midnight to 4 a.m. And the other, 24 to 30 hours a week, they told us that our work week generally would be about 50 to 52 hours a week, was spent either doing some clinical research, doing academics, so either preparing or giving lectures or working on other projects with trainees, and then sometimes just catching up on charting because we were busy. And so, in an 8-hour shift, you might see 30, 40, 45 patients, which is just crazy. It means you're kind of running around nonstop. And so back then it was a lot of paper charting, and we wouldn't always get to them right away. So they would get them sent to the office, and you would go in the next morning and kind of have a stack of charts to finish. And it was a great job. It was an easy place to live. But at the end of my first year, it was kind of apparent that it was not the right balance for us as a young family. Like I mentioned, we didn't have any family in the area, and we felt like every time we had some vacation time, it was trying to prioritize, okay, which set of family do we go see? And I think what was the final straw was my daughter was 5 months old, and on my birthday in February, she got really sick with bronchiolitis, which is a viral infection of the lower airways, and ended up being in the hospital for 4 days. And it just kind of made us pause because, when these things happen and you don't have family in the area, even though, you have your adopted family of friends and other support, it just is challenging. And you end up having conversations like, okay, whose job is more important today? Because, somebody's got to either stay in the hospital, take care of our other child, and manage sort of life uh, challenges while the other person needs to go to work and still move forward in that sense. And it just didn't quite feel right. And we decided that we wanted more support. We wanted our kids to grow up with family. I grew up with two younger sisters, seven cousins, and was just used to having a little bit of chaos and just a closer sense of family. And so we made the difficult decision to move. And at the time, my parents were still in Austin. My youngest sister was here in Austin, but it was scary because Dell Children's was brand new. So I had actually interviewed when I finished fellowship still at the old hospital. And I ended up staying in Cincinnati. When I came the second time, Dell Children's had just opened, but it was really an unknown. And I definitely had mentors in Cincinnati who were concerned that I might be potentially throwing my career away, coming from a top-notch, well-established children's hospital to a smaller institution that had yet to prove itself. But it was a leap of faith, but I did it because it was just the right thing for us as a family. So that was way back in 2008. I cannot even believe that it's been 17 years. So, like I mentioned, when I came, it was predominantly a clinical position. We had very few residencies here in Austin. There were no fellowships. And the group that I joined was a private group that contracted with the hospital to provide pediatric emergency medicine services. But we were independent contractors with that group. So we were not employees, didn't have, you know, benefits, health insurance, 401ks, things like that. So that was a little terrifying because it was brand new to me, never having navigated something like that before. But we figured it out because everyone who worked in our ED was in the same boat, and it was pretty smooth. So in the beginning, like I mentioned, predominantly clinical. So we would kind of do our shifts. We would see some patients on our own, which was kind of fun. And then we would supervise the few residents that we did have. But there was not a whole lot of expectation outside of that. You may help on a project here or there, or help with, a hospital committee here or there, but it really wasn't a large proportion of our day-to-day life. Few years in, we decided to start our APP program, or advanced practice providers. So we had a couple of nurses who had worked with us who went back and got their nurse practitioner degrees. And so we started our program at Dell Children's in the ED of having them start working with us as nurse practitioners. And so my medical director at the time asked me if I would kind of spearhead that project and become the director of APPs, which I did. And he was a great support to me as I learned about admin and how to manage people. And so I did that for a year. And then my director retired, and the new director asked me to be the assistant medical director. So I started that role in 2013. And that was also the first year that our PEM fellowship started. So a lot of us were really invested in growing the next generation of PEM physicians, and were really motivated to turn Dell Children's into more of an academic center. So we were the first ACGME accredited fellowship to start at Dell Children's. We started with 4 fellows, which was super exciting, and kind of learned along the way what worked, what didn't work, but we helped build curriculum. We helped supervise their bedside care. We gave lectures. all of those things. And it was really a blast. And it gave a lot of us physicians um, more of a sense of community, because prior to that, a lot of people would kind of do their shifts, go home. And while we would see each other and sometimes work together on shift, for the most part, we were just kind of like ships passing in the night. And building this fellowship and curriculum really kind of brought us together and solidified our relationships. So 3 years later, Dell Medical School opened, which was also very exciting. And so we had medical students, and with that, more and more residencies grew, more fellowships developed, and things were really shaping up to be much more academic here in Austin. In 2017, our local group became employed by a private national physician-owned company, because that was kind of the direction that emergency medicine groups were growing. The smaller groups were not as stable, and the larger groups did much better because they could leverage size and get resources like risk management and human resources, and things like that. So we all voted and decided to join this larger physician-owned company. And when we did that, we switched over and became regular W-2 employees. So then we got our, insurance benefits and 401 and things like that. And then in 2021, the medical director stepped down. So I became the interim medical director, did that for about a year, and then it became the permanent medical director. And so the medical director is more of kind of an operations title. So running the department, figuring out staffing and kind of throughput metrics and quality measures and things like that. And then I was also named the division director for pediatric emergency medicine, which is more of an academic title. So like I mentioned, we were part of Dell Medical School. All of us have faculty appointments there. Even though we're not employed by the medical school, we still have an obligation to teach all the trainees and to help promote education. And so the division director really is kind of helping guide our group to do those types of things, to be a mentor to the other faculty, to fellows, and more academic related endeavors. So a little bit about Dell Children's Medical Center of Central Texas. So we're the only level 1 pediatric trauma center here in a 46 county catchment area in Central Texas, which is big. So before I moved to Texas, I had no idea how large this state was. Like I said, I grew up in New York, and I grew up in Kingston, which is in the Hudson Valley. So it's a couple hours north of the city. And if we drove 4 hours, we were in another country. We were literally in Canada. And in Texas, you can drive 4 hours and not even be halfway across the state, which is kind of mind-blowing. But we have a 46 county catchment area, which is about the size of the state of Ohio. And Ohio, in that area, has 5 level 1 pediatric trauma centers, and we're the only one. So just kind of puts things into perspective. We have a second North Campus, which is smaller, which opened 2 years ago. And so some of our patient volumes that we were seeing at the Central Campus have kind of shifted north. So our annual volumes now, just this past fiscal year. So at our Central Campus, we have 45 beds in the emergency department, plus we have a 9 bed kind of vertical care area for the more minor complaints. So we have about 54 care spaces, and our volume is about 57 to 59,000 patients a year now. So on a daily basis, we'll see anywhere from maybe 120 patients a day in the summer when we tend to be slower, to, maybe 200, 220 a day in the winter when we're really busy. North Campus volume is about 17,000 patients a year. We have 18 beds there. And our volumes there in the summer when we're slow, probably, 30s in terms of daily volumes. And then in the winter, probably high 60s. We've had some extreme days where, we've been in the 90s, but that's kind of a general idea of how many kids we see a day. And in terms of inpatient beds, we have 299 beds at our central campus and 36 at the North Campus. And our central campus is the training site for pediatrics for the medical school. So we have medical students, we have pediatric residents and other residents, and then we have subspecialty fellows that rotate through. And in our department, so the providers that we have, so we have PEM physicians like me who staff it. So in their primary residencies are either in pediatrics like I did, or emergency medicine, like I mentioned, was another route you can take also. And we have pediatricians that also work in the emergency department. So these are folks that have done the 3-year residency but did not go on to do a fellowship. And so they will see some of our lower acuity patients in more of like an urgent care type of setting. And then we still have a good group of APPs or advanced practice providers who work with us. And then again, our trainees. So we have our PEM fellows. Right now we have 13 fellows. And then we have residents that rotate through us from several different programs. So we have a pediatrics residency. We have emergency medicine residents actually out of 3 different programs. So we have a program based out of Dell Medical Center here in Austin. And then we have 2 military programs who send their residents to us. Family medicine residents here in Austin rotate through with us too. And then we also have transitional year residents. So these are residents that are going into things like radiology, dermatology, ophthalmology. And for their first year of their residency, they can choose whether to do a surgical year, a medical year, or what they call a transitional year, where you get a little bit of everything. So they do some surgical rotations, they do some adult medical rotations, and then they do some pediatric rotations too. And then we also get medical students that come through with us. And then we get some APP fellows from the military. So these are licensed and fully practicing APPs, but they want to do additional training to increase their competency in emergency medicine specifically. So they spend time in the adult emergency departments and then with us learning pediatrics. So what does it look like if you are a full-time PEM physician here at Dell Children's? So we have a minimum hour requirement every month that all full-time people have to meet in order to get benefits. And so that usually translates to be about 11 shifts a month. And some people just want to do on the low end, and so they may choose to do 11 or 12 shifts. Some folks choose more, and typically our highest shift people do about 16 shifts a month, which I know it doesn't sound like a lot, but when you factor in kind of circadian rhythm and just transition progression of shifts and kind of rotating back, it's enough. The way that our compensation model works is there is a hourly rate that everyone gets, and then there's a productivity component too, which depends on how many patients you see and how acute their complaints are. So if you don't see that many patients in a certain shift because you had a really critically ill patient that you had to do a bunch of procedures and, consult the ICU and things like that, then that just kind of helps offset, what you might feel because you're seeing fewer patients. So we think that model works really well here. There are different models that are different, but this is what ours has been for several years and everybody likes it. We also offer a differential. So if you work an overnight shift, if you work certain major holidays, then you'll get paid a higher hourly rate for that because we know those are the least desirable shifts to do. And then for us, we give an academic bonus twice a year to our faculty for all of the things that they do with the PEM fellowship, whether it's like this picture here, ultrasound workshops, whether it's giving a lecture, whether it's serving as a research mentor, or writing an article, book chapter with a fellow, all of that counts. And we choose to do it this way to give people flexibility. Some people have a lot going on in life and they may not have a lot of bandwidth to do a lot of academic things. Some people love it and want to do more. And, your availability might change from year to year. So it just gives us some flexibility. And that way, the people who are doing more are compensated for it, and they don't begrudge the people who are doing less, because they know that that it's all valued and that they will get paid accordingly. And like I mentioned, we are all faculty in the Department of Pediatrics at Dell Medical School. And I already mentioned kind of some of the roles that come with that. So bedside teaching we do every shift because we always have trainees. We give lectures, or we mentor fellows or residents when they give lectures. We do hands-on workshops. We help with research and just kind of career mentorship. Like I mentioned, there are other models that don't look quite like what ours does at Dell Children's. So when I was in Cincinnati, for example, that was a very typical academic model where you have a fixed salary. So everyone who signs on gets paid exactly the same, and you just have allotted time, or quote unquote kind of buy down time for your academic or research duties. So if you say we're at an academic facility and you took on a job as the ultrasound director for the emergency department, you wouldn't necessarily get paid more. They would just cut down on your clinical time and give you more protected time to do your ultrasound duties. So that's one way that most academic facilities choose to do it. And then obviously in those settings, you are working with trainees pretty regularly. There are also community jobs where you go and just see patients, and you don't have trainees and you don't have other job responsibilities outside of just seeing your patients and going home. And this was more what Dell Children's looked like when I first started 17 years ago. And again, different models there. It could be anything from just a fixed hourly rate to what our model is, where you have an hourly rate plus a productivity component. And some sites do productivity only. So, if you have a really slow day, you may not get paid that much. But if you're really busy, then you're kind of compensated extra and you make up for it. Community sites can be pretty variable. They can either be really busy and you have multiple physicians on at a time, or they can be really kind of small and slower paced, and you may be solo coverage the whole time. So the way our shifts work right now for our PEM physicians, so at our central campus, like I said, this is our level 1 trauma center. We're pretty busy. So we all split our shifts between the two campuses, but we do about 75% of our shifts at the central campus. And this is our current shift map because we're still coming out of winter and our volumes are still pretty high. So we have 9-hour shifts a day, and we do what we call waterfall scheduling. So we pack in more coverage when we know more patients are coming in and our ED is going to be really busy. And then we kind of taper off in the early morning and late overnight hours when we tend to be less busy. And then our North Campus, because it's smaller, we have single PEM coverage. So we do 2 12-hour shifts out there. And then we have 2 mid shifts during the day that are covered by either an APP or a pediatrician. So they help us where we're busy. And then we have that same model at the central campus too. So we kind of run our front end as a fast track. And so for the busy hours of the day, about 12 to 16 hours, we will also have either an APP or a pediatrician up front helping with that volume. So I don't know if this is too small for you guys to see, but this is just kind of a snapshot of a 1-month schedule for our typical PEM physician who does, I think he's got 13 or 14 shifts here. And so we try to respect circadian rhythms and kind of group days together or evenings or nights together. And then if you have multiple in a row, we're going to try to do a progression when we can. So you're going from earlier. So you might go from day, evening to overnight, and obviously not backwards. So this is Dr. Thompson, what his schedule is for May. And so you can see on May 1st and 2nd, he has 2 evening shifts. So there's 6P to 3A back to back. And then he's actually got 5 days off. And then he has 2 day shifts. So a shift at North, which is a 12-hour shift, and then a day shift at our central campus. And then he has 3 days off. He works a day shift, has a couple days off, works in the evening, so 3 to midnight, has a couple days off, and then he has 3 nights in a row. Probably because he asked for them to be in a row. Some people want them all together because then they just flip their sleep cycle and they get all their nights knocked out in one fell swoop. Other people don't recover as well. They really like to have them separated, so their nights might look a little bit different. They may do, 1 night a week or however they choose to. But he's got 3 nights in a row. And then we try to give everybody 2 days off after their last overnight to kind of get their sleep cycle flipped back around to work different shifts. And then he's back on for 3 day shifts. And then he's got the last 5 days off in the month. So, like I said, some people do a couple less, some people do a couple more, but it's easily doable. I wanted to take a couple minutes just to kind of describe what a PEM shift might look like. So this was my shift probably about a month ago. So it was a 6 a.m. to 3 p.m. shift. And just to kind of show the different things that we might see. So when I walked in at 6 a.m., of the patients who were still in the department overnight, I had 3 sign-outs on mental health patients who were boarding in the emergency department. So 3 teenagers, 2 who had attempted suicide but had been medically cleared, and then 1 who just had suicidal ideation but not an attempt. And so those are kids who are really high risk. So they're not stable enough to be sent home, but mental health beds are really hard to come by, particularly in pediatrics. So this is a phenomenon across the country. And we're actually lucky in that our hold times aren't as high as many other places. So they were still holding. So I, just kind of eyeball them, make sure their medications have been ordered, that they don't have any new things that have popped up, and then touch base with the social worker on what the plan is and whether we have potential transfer opportunities for mental health beds. So luckily there were only 3 that day. I would say my personal record walking in was 13. So it depends on just the season, because spring tends to be some of our worst times. I think the kids get really anxious about some kids, graduation, about, prom and all the social anxieties with that. A lot of standardized testing in the schools occurs in the spring. So springtime tends to be a little busier. But so I had 3 that morning. And then my first set of patients was 3 siblings who all came in with pretty similar symptoms. So we call that a threefer. And usually you can pinpoint that there's one that the family's truly worried about, and the other 2 are just kind of along for the ride. Not always true, but usually you kind of just have to figure out which one is the sickest. So in this case, it was the baby, 13 months old. They all had fever, cough, and congestion, but the baby had a seizure. And so that's pretty common. So about 1 to 2% of the population will have what we call a simple febrile seizure. And we see it in kids anywhere from 6 months to about 5 years of age, typically in the first 24 hours of fever. So what he had was very consistent with just a simple febrile seizure. He looked great by the time he was in the room. So we actually don't do a whole workup from a seizure standpoint in the emergency department, unless there are red flag things in the history or physical, but he didn't have any of those. But because he's young, he had new fever. So, and because, March, we were just swamped with flu, I did a flu test on him. That was positive. And so offered him Tamiflu. And then the other 2 were his 7-year-old brother, 4-year-old sister. And so they looked great, really nothing worrisome on their exams, but we swabbed all of them for flu. and only 2 of them came back positive. So we know that third one has flu too, but just for whatever reason, either we didn't get a good sample or she was early in her course of illness, didn't test positive. So they were all fine to be discharged. So 2 with a diagnosis of influenza and the third with a diagnosis of influenza-like illness because we couldn't call it actual flu. So that was pretty easy. And then we got a really sick kid actually who came in to triage. So he's 11 years old and has a chronic medical condition to where he has an ileostomy. So he has his ileum actually has been connected to his abdominal wall, and so he has a pouch to collect stool and all of that because the rest of his intestine and colon was not appropriately developed. So he had been sitting at home for several days with vomiting and abdominal pain. And I think he had like moments of looking better. And so the family said, well, he's done this before, and a lot of times it gets better. So we just kind of watched it. And they watched him for a really long time. So they brought him actually up to triage. He didn't even come in by ambulance. But our nurses are amazing. And they recognized that this kid did not look well at all. So they rushed him back. And so we put him in our resuscitation bay. And this kid was really sick. I mean, he was so unstable that he couldn't maintain his temperature. He was really hypothermic. He was really tachycardic, meaning his heart rate was really high because he had been vomiting and not taking in enough. So he was really dehydrated. He looked pale. He was super uncomfortable. And so we got all hands on deck in the resuscitation bay. So all of our nurses and techs to make sure that we get IVs placed right away, that we start fluids, we get labs going. And because he has this ileostomy and he was having vomiting and his belly was really distended and tender and he's having kind of bloody drainage from the ileostomy. So I consulted surgery to come see him. We got x-rays and stuff. And we ultimately got him warmed up a little bit, gave him fluids. He looked a little bit better with fluids, but still not great. And so we admitted him to our ICU for just monitoring to kind of resuscitate him and to get his electrolytes a little bit under better control before we did more testing and decided whether he had to go to the OR to evaluate what was going on with his ileostomy. Well, when he got to the ICU, he actually got really sick. He had a cardiac arrest. So they had to do CPR for about 15, 20 minutes before they got him back. And they just couldn't get him stabilized. So they decided to take him to the OR, even though he was unstable, to explore what was going on. And what they found was a volvulus, where his bowel was actually twisted around the site of the ileostomy. And so he had injury to the bowel because it had gotten necrotic from not getting enough blood flow. And because of the arrest, he had some kind of brain injury associated with that too. So he's actually still in the hospital. It's been over a month, but luckily he survived. But that, early in the morning, if you're busy, can really cause the department to come to a screeching halt, because this is when you tend to have your fewest resources, because typically we're not that busy at 6 a.m. So you may only have, 5 or 6 nurses and 1, maybe 2 PEM attendings. And luckily everyone else in the department was stable, but always something to kind of keep in mind. And then the next patient I saw was a 10-year-old girl, actually came in because mom was worried that this could be measles. And so the charge nurse put her back in. We have a negative pressure room because with measles, it's so contagious. You have to be really careful. But she looked really well, didn't have a fever, just kind of had this rash. And with pediatrics, there are a lot of funky rashes. And just with experience, you tend to learn sort of the common patterns. So thankfully, hers was pretty easy. So I was able to see her and reassure mom right away. Because once I saw what the rash looked like, okay, I said, this is what we call pityriasis rosea. It sounds fancy and scary, but it really isn't. It's pretty it self-resolves and you don't have to do anything other than supportive care. So, but, I got gowned up, put on my N95 just to make sure that I wasn't potentially exposing myself or anybody else to measles before I kind of got the whole story. But luckily, she was able to get discharged home. Then there was an 8-year-old who came in with some abnormal movements. And mom wasn't sure whether these were seizures or not. They didn't really look like seizures, and he otherwise looked well. There was nothing concerning about the rest of his history or his exam. So we actually didn't have to do much for him because he had a totally normal neurologic exam for me. So we talked to neurology, got him follow up in clinic, and were able to get him discharged pretty quickly. And then 8-year-old ear pain, again, very straightforward. Ear infection, went home on antibiotics. Then things, get a little interesting. We have a 4-year-old with fever and cough who looked a little bit puny, but not terrible. So we got a chest x-ray that was consistent with pneumonia. Looked a little bit better once we got the fever under control and oxygen levels were normal. And so that one did not need to be admitted to the hospital, was able just to go home with oral antibiotics for their pneumonia. And then a 12-year-old boy from a group home who was a terrible historian and giving us really vague complaints like, my nose has been bleeding, I have discharge from my nipple, and sometimes my belly hurts, my ankle hurts. And so those are the ones that you have to stop and take a little bit of time and kind of sort through, like, are these all connected? Are they completely unrelated? What's real? What's not? Like, what's the main concern that the staff at the home have? And he looked great, did not have an active nosebleed. And so he was able to be discharged back to the group home as well. And then we had a 10-year-old, another chronic patient who had a dislodged GJ tube. So some kids are not able to take in adequate calories by mouth, or they're risk for aspiration, and so can't take things by mouth. And so they need what we call a gastrojejunostomy tube. So this is a tube that goes through the skin, and it has two ports, one that ends in the stomach and then one that goes through the intestine and ends in the jejunum. And so these tubes are a little bit harder to place because of that jejunal portion, because it's a long tube and you have to make sure it goes in the right place. So the typical just G tubes or gastrostomy tubes, we replace those all the time, but a GJ tube actually has to be replaced by an interventional radiologist down in the fluoroscopy suite. So we had to call and coordinate when the radiologist would be available to do that, but we were able to get that situated and he was able to go home. Then we had a 10-year-old girl who came in with calf pain. She couldn't walk because her legs hurt so bad, and she had had fever, cough, congestion. And we know that influenza is very commonly associated with muscle inflammation or myositis. Sometimes that's all it is, and the muscle enzymes are a little bit high, and all you have to do is give IV fluids and just pain control, and they get better. Just lots and lots of hydration at home. Sometimes those enzyme levels are so high and they're so uncomfortable that these kids need to be admitted to the hospital to make sure that they improve, because we don't want kidney damage to occur from some of those enzymes depositing in the kidneys. So luckily, she was stable. Her numbers weren't that high. With some ibuprofen, with some fluid, she was able to walk, although gingerly, and we were able to send her home with just good return precautions. 18-year-old abdominal pain, diarrhea was just viral. That one was able to go home without too much. 4-year-old history of acute lymphoblastic leukemia, who actually was pretty well, but she was having a really hard time with dressing changes and at a developmental stage where was just really putting a lot of fight in with her mom at home. And there was some concern that maybe there was some leaking or bleeding. And so she actually got sent into the emergency department by her oncologist to have our oncology unit nurses come down and help mom do the dressing change. So luckily, everything was intact with her central line, which is where they get their chemotherapy and stuff. And we didn't have to do anything too crazy there. So they got her dressing changed and she went home. I had another new patient with suicidal ideation that we kept in the emergency department, just pending placement. And then I had a 12-month-old baby who came in with fever and just not quite acting right. And on this one, what I found was he was only partially vaccinated. And because of that, he didn't get all of the vaccines that would typically protect you against the common causes for bacterial meningitis. And so it took a bit to talk through that with the family and convince them it was safe to do a lumbar puncture, to just fully evaluate why the baby was acting the way he was. And thankfully, they let us do the procedure, and he ended up actually having bacterial meningitis. So that one got admitted to the hospital and luckily did well. Some of these babies get really sick. They can have abnormal brain imaging, they can have seizures and a lot of developmental delay. But I think for his case, we caught it early enough to where his course was actually pretty unremarkable. And then a couple more just sort of minor complaints that were able to go home. So a 5-year-old with painful urination. There's a boy who was uncircumcised and he had what we call a phimosis, where the foreskin is just so tight in the front that you can't retract it. So he was not able really to fully expose his urethra to be able to urinate with a strong stream. So, he's basically trying to urinate through a tiny little pinhole. So as you can imagine, a lot of pressure was building up in his bladder, trying to force the urine out. And that's why he was having pain. So a lot of people think, oh, painful urination, it's probably a urinary tract infection. But this is a good example of where a physical exam is so important because it could be so many things. So he was fine. We did a bladder scan with an ultrasound to see if he was retaining urine after he urinated, but we could demonstrate he was able to fully empty his bladder. So he was able to go home. We gave him some steroid cream and follow up with our pediatric urologist. Had a 3-year-old with eye swelling that was from a bee sting. Biggest thing there is you want to make sure they don't have a severe allergic reaction like anaphylaxis, which he didn't. And we want to make sure that bee sting didn't turn into a bad infection, because around the eye, that can be pretty serious and require IV antibiotics. His luckily was fine. Excuse me. And he was able to go home just with Benadryl. Then we had a 4-year-old who fell just ground level, hit his eyebrow on the corner of a nightstand and had a laceration. So in pediatrics, we use LET gel. So it's lidocaine, epinephrine, and tetracaine. So it's a little gel we put over the laceration, and it does 2 things. It constricts the blood vessels, so it stops bleeding. And then it also numbs the skin. And so that way we don't have to inject them with a needle to give local anesthetic. And that is the most terrifying and uncomfortable part about doing a laceration repair. And then other techniques that we use, we have child life specialists in our emergency department. So these are people actually with a master's degree in child life who come and do distraction techniques and other things like some kids want to know exactly what happened, so they'll talk to them in developmentally appropriate language to explain to them what's going to happen. They help with distraction and other things, and they're invaluable. And then we'll also sometimes use some nasal medicines, typically with fentanyl and Versed to help with pain and anxiety. And it doesn't knock them out. It just relaxes them enough to where they let us do the procedure. And usually with a combination of all those things, you'd be surprised at how well these kids do. We sometimes have kids fall asleep because they're so relaxed when we do the repair. So that one we were able to do and go home. Then I had a 4-day-old baby come in. He was a 35-week premature infant, so born a little over a month ahead of time, who came in hypothermic. So hypothermia in a baby could be so many things. It could be a serious bacterial illness, could be just exposure because, it's cold outside. And sometimes it's just a premature baby whose brain isn't quite mature yet and they just can't quite regulate their temperature. Maybe they accidentally get exposed for too long during a diaper change, or sometimes it's a doctor's appointment and they get a little cold. So he looked pretty well, but he was small because he was a preemie, so it didn't have a lot of kind of body fat to help protect him against hypothermia. So that baby, we initiated a bacterial infection workup. So we do blood work, we did urine, and we actually did do a lumbar puncture just to make sure we weren't missing anything. And then that baby got admitted to our NICU for observation. Then there was a 14-year-old who was at soccer, had a really forceful kick, and then developed sudden onset left hip pain. He looked well, otherwise didn't have any other associated injuries that we had to worry about, like a bad head or neck injury. And so on x-rays, he had a little avulsion fracture of his left hip. So basically what happened was his muscle was stronger than his bone. And so as the muscle forcefully contracted, it pulled off a tiny piece of his hip bone. So had a little fracture. So with hip fractures, obviously we can't cast those, but for little avulsion fractures like that, we treat that pretty conservatively. So just non-weight bearing, we put him on crutches, and then he follows up with orthopedics and they just watch him, but he should heal just fine. And then the last one was a 12-year-old with abdominal pain and vomiting and pretty focal right lower quadrant pain. So we were suspicious for appendicitis. So got blood work and then got imaging that confirmed appendicitis. In the adult world, we do a lot of CT scans because it's quick, it's easy, and it gives you a ton of information. We really try not to do CT scans whenever we can in kids because CTs are associated with ionizing radiation. They're still young, they're growing, and they have a higher risk to develop malignancies. And so we have moved towards doing either a fast MRI of the abdomen or an ultrasound of the abdomen. And luckily, most of the time we can diagnose appendicitis with one of those tests. So pretty typical day. I didn't see at least, other significant trauma that day. But, by the time my shift's done, there are other physicians who are also picking up patients. So their snapshot that day may look totally different than mine. But this is one of the things I love about PEM is like, you just never know what you're going to get. Every case is different. Every day is different. And it's a nice combination of medical management and being able to do some procedures. So outside of your clinical shifts, there are also tons of non-clinical opportunities. And this is what I encourage my group to really try to develop. Like your first couple years out of training, you're just focused on being a good clinician and getting your feet under you. But after that, I really think it's important to try to develop some other interest that will sort of carry you through and hopefully grow as you progress in your career so that your proportion becomes more non-clinical and less clinical as you age, because I think this is what's going to give you longevity in a career like emergency medicine. So this is just a brief list. It's not even comprehensive of things that some of our PEM physicians are doing. So simulation, advocacy, global health. Dr. Thompson, whose schedule you just saw, he's actually going to Kenya in a couple of weeks. So he does that once or twice a year. Clinical innovations. POCUS is point of care ultrasound, quality improvement projects, peer review, outreach to the community, to other emergency departments to support their pediatric care, EMS, pediatric readiness, which is somewhat related, disaster medicine, toxicology, and academic leadership. So you can be a program director for a residency or a fellowship, and then other kind of department and hospital leadership like I'm doing. So my current roles now, I've already mentioned, I am the division director and medical director for PEM at Dell Children's. And within the Department of Pediatrics, my faculty rank is Associate Professor. So we can apply for promotion every 7 years or so. So my typical week now, because I'm very admin heavy because of all of the things that I have to do. So I'm typically about 12 to 22 hours a week clinical. And then the other, 30, 40 hours a week is all administrative. So doing meetings or teaching, following up on complaints and emails and things like that. But outside of what I do here at Dell, I also have a couple other projects that I do, which I love. So there is a summer camp about an hour and a half outside of Austin called Camp Longhorn. And so I serve as the medical director for that camp. So typically during the winter, not a whole lot to do other than help figure out staffing with nurses, physicians to cover the health center. And then I might review our health center policies, procedures. I review camper applications in case kids have medical conditions and we need to see if they're appropriate to come to camp, or parents have questions about vaccination status, things like that. But the bulk of the work for camp obviously is during the summer. When they run 10 weeks between June and August. And luckily, that's also when our emergency department tends to be the slowest because kids are out of school. It's not, flu and RSV season. People are traveling. And so, like I mentioned earlier, sometimes we see half the volumes in the summer that we do in the winter. So we tend to cut a lot of shifts in the summer because we just don't need that many people there. And so a lot of my group helps cover at Camp Longhorn. So we'll go out there for a week at a time usually and just be on site. And it's a nice break from the hospital because you're working, but you're also much more relaxed because there's a lot of built-in downtime where you can go out on the lake or take a nap or float the lazy river. And so it's a good reset for a lot of our group. And then a couple years ago, I signed up to be an expert panelist for the Texas Medical Board. And this is pretty low commitment in terms of hours. So what this means is if there's a complaint that comes up in my specialty, so pediatrics or pediatric emergency medicine, that they need reviewed from a quality standpoint, then it may come to me. So they typically have 2 to 3 reviewers for each complaint that comes up. And I've had a handful of them offered to me. A couple of them were during times where I couldn't get back to them, right away because there's a deadline of usually a couple of weeks to turn over the cases. One I've done, and then one actually it was a physician in Houston, but I knew them. And so I thought it's a potential conflict. So I declined that one. But this is kind of a nice way to give back and support your fellow physicians. And also is a good learning process for me too on how complaints work through the medical board. So that's kind of what I do. And this is just, again, a little snapshot of what last week looked like for me, just to give you guys an idea. So Sunday I was off. I had 3 clinical shifts last week. They were all 6 a.m. to 3 p. shifts on Monday, and then Friday, Saturday, and this past Sunday, which is not on here. And then the other 3 days were admin days for me. So I had kind of meetings in there, and we had a PEM happy hour Wednesday evening that I hosted. And then in between kind of the meetings and stuff was just looking through emails and, other one-off phone calls and just little fires to put out. But at least it's a little bit more flexible. And some of these now, thanks to COVID, are hybrid meetings or virtual. So we do have some flexibility sometimes of, working from home, which is a nice change because pre-COVID, we really didn't have that option. Some of the committees is just an example list of certain things that we have that I happen to sit on, but there are so many others that I do that other people do that aren't on this list. So anything from just peer evaluation committees to a pharmacy committee. We have committees looking at unplanned transfers. We have committees looking at all code blue events that happen in the hospital, things like stroke patient reviews. And I have one committee that I sit on for the company that I work for. It's the National Clinical Governance Board. So I'm kind of the pediatric voice on clinical issues that might come up. And then I am part of the faculty senate for the Dell Medical School too. So if I were to summarize kind of PEM as a career, what I think are some of the pros and the cons, for me, the pros obviously outweigh the cons, but the biggest thing is just the camaraderie. So we, like I said, are a big enough site to where we have, during the busy times of the day, multiple physicians who are there together. And these are people that you spend, days, nights, weekends, holidays. So you really bond and they truly are your family. I mean, if you think about it, they're there through the terrible cases that come in and help support you as you process that because it doesn't always end with a good outcome. And they're there to celebrate the wins when you have a great save or do a really um, difficult procedure or you have a great outcome that you weren't expecting, then they're there to celebrate with you. So really, you have to have that tight connection with your group at work. Otherwise, you're going to burn out. So we're super lucky that we have an amazing family. We truly think of ourselves as a family. And so that I think is a huge pro. Flexible scheduling too, when my kids were little, I could be at almost every field trip, holiday party. I never had to grocery shop at HEB on a weekend because, the way that our schedules work, I could do all of those errands during the week without too much difficulty. And we don't have to worry about having fixed, patient panels that are scheduled to where if something comes up last minute, you can't move a shift or cancel. Like we just all cover for each other. And then relatively speaking, we here, because we do have an academic component that allows us to decrease our clinical time, like it's fairly low burden clinical hours. 11 shifts a month really isn't that bad. You can obviously do more if you want to earn more, but the minimum requirements are really not that hard for us. And also with emergency medicine, there's no real on-call responsibility. So you work hard on shift and then unless you're doing a lot of admin work like I am, when you go home, you're kind of done. And so you don't have to worry about constantly having your phone on you and being available for things that pop up. And then, like I've already mentioned, there's just a variety of complaints and a great balance, I think, of medical management, of being able to do procedures. And because our fund of knowledge and what we have to know is so widespread that a lot of the non-clinical opportunities that are out there, we are able to take advantage of. And so you really have a lot of flexibility in choosing how you balance your time between your shift work and what you're going to do outside of that. The cons, emergency departments, hospitals never close. So it's a 24-hour job. So somebody has to work the nights, the weekends, the holidays, and that's just part of it. And you kind of just have to learn to accept that. There can be disruption to your circadian rhythm if are working a lot of evening to night shifts. Like I said, we try to do what we can from a scheduling standpoint to minimize that disruption, but I think as you get older, that can be harder to do. And so at our site, we actually have a policy where once you turn 55, you are not required to do the deep overnights anymore. And then between 50 and 55, we'll cap you at no more than 2 a month. But if we can get you lower than that, we can. So I think that helps too if you end up at a institution that recognizes that these things are difficult and has a plan in place to address them. And then stressful situations. I mean, this is not for every personality. Some people like their routines and know where they're going to be and what they're going to see. Like in the ED, you never know what's going to happen. Some people love it, some people hate it. So you just have to think about your own personality. And for us, most of us, there's not necessarily designated vacation time. And so for our position here, you either just shift your clinical hours to the time that you are in town or are working, or you do fewer shifts that month, but you may earn less that month. So people do it both ways. Some people just take the cut and pay and do fewer shifts, and some people just move their shifts so that they may work more in the other weeks. But it also gives you some flexibility. I mean, we have some partners who take a vacation literally every month or every other month, and you don't have to worry about how much PTO time you have because as long as you're doing your shifts, you can do whatever you want with the rest of your time. So that's basically all I have. These are just some fun pictures of our group. So in the top left, we had an education day where it was toxicology and we were talking about envenomation. So we had the snake guy come and bring some friends. So that was a big hit. We do retreats at least once a year as sort of team building events. And so this was on our 2-day retreat where we were doing some games of the ladies versus the guys, and the ladies won. So we were pretty happy about that. And just kind of fun on shift, celebrating birthdays sometime. People get dressed up for Halloween or ugly sweater days around the holidays. And then the last one in the bottom left, we did a game show night. And this was the team that won. And the name that they chose was Syphilis Whispers, but they were pretty proud of their prize. But like I said, so much just camaraderie and family. And so I would say that's the biggest strength. So that's kind of everything. I know I talked for a really long time, but curious if you guys have any questions, anything that I could clarify for you.
So I'll probably have about 10 minutes of questions. Then I'll speed run your how to get a certificate. One of the questions that someone asked was, and I warned you in the first place, is about the MCAT and how you managed your time to study and prepare for the MCAT before applying to med school, and how long did you spend preparing for it?
Yeah, I'm gonna tell you it's hard for me to remember because it feels like it was a lifetime ago. But I remember just setting aside, I would study whenever I could, but I would study during the week, and then I would set aside like a couple of hours it was either Saturday or Sunday morning, and I would run through practice tests every weekend for a couple of months before the exam, because that way, by the time you walk in and take it, it just feels pretty natural because you've already been doing it. And I did do a review course back then. I think it was Princeton Review. I don't know if they're still around or not, but I felt like that helped really structure what my studying looked like, and it helped what I was doing on my own too.
Definitely makes sense. Most people, just for the recommendation, recommend at least 350 to 400 hours of studying for your MCATs. That's just like a general number though, but that's usually the prepared thing. And then someone else said, "Hi, pre-med student here. Can you give me some advice on, or possibly a key takeaway for working in a field with children or adolescents as the main demographic?" And then I'll ask the second question in a bit.
Okay. Yeah, I think it's recognizing that for the most part, kids are healthy, they're motivated to get well, there's not a lot of secondary gain. And so you mostly trust what they tell you, no matter how kind of crazy it might sound. And also just realizing that there can be a lot of frustrations on kids who are nonverbal, either because they're too young to tell you what's going on, or because they have developmental delays or other challenges that make it difficult for them to communicate. And so you have to be just really astute and listen to what the caregiver is telling you or what your exam is showing you to try to figure out how to help that patient. And then I think what a lot of people might not think about sometimes is, even though your patient is the child in front of you, your patient is also the parent or the caregiver that's there with the child. And so it's addressing their concerns as much as it is addressing the child's concerns.
Yeah, and so then he also followed up with also referencing your PEM shift snapshot slide. How do you personally balance such a heavy caseload, especially in those early morning hours when resources might be limited?
Yeah, it's all about triaging. So, you just have to think about, okay, who's the sickest kid in the department and who needs my time and energy right now? And obviously, it was that 11-year-old kid. And you just have to trust your staff that they know when to come get you when something bad is about to happen. So, like I said, all those other kids that were there early in the morning, they were all stable. And so the nurses have a good enough ratio to where they typically don't have more than 4 patients as part of their caseload. And so they're in the rooms fairly often and will tell you if something's about to go south. And I think just also knowing when to delegate. So those were not all patients that I saw on my own. I mentioned a lot of times we have fellows who are there, we have residents who are there. So just knowing what you can trust them to do independently, when you need to be at the bedside with them. And we also just communicate with each other. So there are times when there are mass casualty events because there's a big bus crash or something has happened, and so we have a big WhatsApp group for our whole team, and we will send out SOS texts sometimes, like say, hey, 20 kids just checked in and we're overwhelmed and we need help, especially at our North Campus, right? Because you only have one PEM physician and you may have two pediatricians or APPs, but that's three people. And if they get overwhelmed, it can be really hard. And so we just are in constant communication, and either we'll ask someone to come in extra to help, or we may shift resources because sometimes the main campus isn't that bad, and we can send someone from the main campus to the North Campus, or sometimes vice versa. So it's all just about communication.
Okay. I have three last questions for you so that we're mindful of your time and also finish up because I know we're going over a little bit. So hopefully no one else is bothered by that. So their next question is what do you personally look for in terms of personal qualities in med students that first come into the hospital?
I think it's really a willingness to learn, like a true curiosity. And even if you may not be going into pediatrics or to PEM, like there's something to be learned from every case, from every rotation. So just having a true curiosity, and working hard, and just doing everything you can to get the most out of that rotation. There's nothing worse than when you can tell that a resident or a student doesn't want to be there. They're bored, they're not listening, they're sitting on their phone or computer, they're not actively picking up patients. Or sometimes we offer them something what we think is cool, like, hey, there's this great case, you might get to do a procedure, and legitimately we have had people tell us, oh no thanks, I'm not going to do that in my career, so I didn't want to see that patient. That's never the right answer.
Yeah, that definitely doesn't sound all that great. An international med grad said, what experiences do you recommend they pursue to stand out when applying for pediatric residency or PEM fellowship in the United States?
Yeah, I think, just like I said, something that kind of stands out. So we have a fellow who's coming who is also an international graduate, and she worked as an ultrasound sonographer full-time for several years and did that as she was going through the process of applying and getting admitted to residency and then to fellowship. And such a great skill, not everybody does that, but in terms of like her value, like what she's going to teach her fellow trainees, to the nurses, to us as faculty, the research projects that she can do. And plus, you could just tell like she had a true passion for doing that. Like that's what really comes across, was when you have something that you're really invested in, that you are going to continue to foster during your training, I think really comes across.
That makes sense. We do have a high schooler, awesome enough.
Great.
And they said, what do you think is important for high schoolers to do to prepare for a career in pediatrics? Being in Austin, are there any internships or summer programs that you know about that would be helpful for a high school student?
Yeah, I think any exposure that you can find is great. A lot of high schoolers have a great relationship with their pediatrician. So even just asking your pediatrician, hey, like, can I come shadow in the summer for a few hours? Can I volunteer? Can I even, just like file paperwork? I mean, everything's digital now, but, little things like that just to kind of get you in the door. And it's really about who you get to know, and then someone always knows someone who knows someone, and then like once you kind of get your foot in the door, it becomes much easier as other opportunities open up.
That makes sense. Okay, I'll throw a last one in there. Is do you work with physician assistants, or do you know other PEM physicians who do? If so, how do you interact with them and how does that relationship work?
Yeah, we have PAs, they're part of our APP team. So our APPs are both physician's assistants or PAs and nurse practitioners. And so we utilize them both. And we have a really strong relationship. We have a list of guidelines that we follow. So there are certain, higher risk cases that they have to run through us as the attendings. And then everything else is kind of up to their judgment. So they can do procedures, they see patients on their own, anything sicker, they come talk to us about and sign out to us. But they're really an integral part of our team, and they really help with our flow. When we're bogged down in a really sick resuscitation, they keep the rest of the department going. So I think most emergency departments utilize APPs in some respect, and so that is not hard, even in pediatrics.
Well, I want to be mindful of your time. I do see Courtney has her hand up. Would you mind answering one more question?
Oh yeah, of course.
All right, Courtney, you want to unmute yourself?
Yes. Hi. I'm
Hi.
a pre-med student currently in my sophomore year of undergrad, and I was just wondering if you don't mind sharing what was like maybe like a pivotal low point that you had either in your undergrad career, um, in med school or fellowship or anything like that, and how did you navigate that challenge and use it as a learning lesson for future processes?
Yeah, that's a great question. I think, undergrad is just sort of the stress of not knowing, like, am I a competitive applicant? How am I going to do in this in this class? Like, is one bad grade going to tank, all of my future aspirations to get into medical school? How am I going to do on the MCAT? And there was a class that I particularly struggled with, which was social psychology, which most people thought, oh, it's a blow off class. It's not going to be hard. But for whatever reason, I really struggled. And there was a point where I was terrified I was actually going to fail this class. And, typical type A personality, I had never failed anything before. And I, in my mind, thought this was going to be the end of the world, and it took my dad saying, like, it's one class, who cares? And I always thought my dad was the smartest person I knew. And he's like, oh, I've gotten bad grades, I've failed, and I'm still successful. He's like, don't worry about it. Just do what you can. It's one class, we'll figure it out. And he's like, okay, you don't have a choice. You just kind of have to struggle through it. I ended up with a C, which I never thought I would be thrilled to get a C, but I'm just glad it wasn't an F. And you know what? He was right. Like at the end of the day, does anyone know about or even care about one C or whatever? So things that you think might be insurmountable usually aren't. So you just kind of have to have a little grit and just push through and just have faith that things are going to work out how they're going to work out. I think further along, sleep deprivation was tough, especially as I got further along, had kids and additional responsibilities. And it's like trying to juggle, like, okay, which part of my life needs to take precedent today? And you just sometimes just put your head down and get through the day. And again, just have faith that everything's going to work out. And it always does, right? Tomorrow always comes, and things that you think are the biggest deal in the world, after a night of sleep, you're thinking, okay, why was I so obsessed about that? Like, it's fine, and I'm going to move on, and there's something else to worry about today. So I think just know that everyone has been through what you're going through, that you're not going through any of this process in a silo. So just rely on your resources, reach out to people who have done it, and just know that everyone wants you to succeed. There's so many more resources now, so many more guardrails in place to protect you know, students, residents, even attendings from just a job safety, mental health standpoint than there were, 20, 30 years ago. So just don't worry too much about it. It's all going to be okay.
Perfect. Thank you so much.
You're welcome.
I love that. Well, I'm going to share my closing slides and just say thank you so much for your PowerPoint and your presentation, all your information. And I loved seeing all of your caseloads. I know a lot of people kind of go into it and they just see the quote unquote cool cases. So it was nice seeing your just daily work schedule. That was very unique and very amazing. So to close out after the thank yous is we generally say it's nice to reflect on anything that you do in the pre-health world. And three of our top questions is what brought you today? What are your three major takeaways? And what do you want to learn about? If you actually write these down and if you feel comfortable posting them, we do have a LinkedIn and we do sometimes post those or repost those reviews or those insights on LinkedIn. So it's a great way to grow your social network, but also to get your voice out there and have people see that you're involved in the community and that you're open to different experiences and all of these different resources that are available to you. So if you'd like to do that, feel free to post that, or you can even just email it to us at info@prehealthshadowing.com, and we're happy to look through those and post them. If you want to go on our LinkedIn page, you can see other posts and see kind of what an example of those look like if you need that. So again, if you're interested in being a part of our pre-health shadowing, you can register as a volunteer on our website. It's 100% remote. It depends on you on how many hours you want to do or what your schedule is like. It's very flexible. So if you're looking to do that, we are a very happy team to have more volunteers, and we're a huge network of people who are helping to mentor you and help you in anything that you need help with. Lastly, if you can donate, by gosh, go ahead. There's a QR code right there. If not, no worries. You can also donate your time and be a volunteer. If not, you can also find someone who is. But if you don't, then that's that. On to I guess the best part of this is getting your certificate. You can go to the sign up page for this session or any session that you even watch. You can go on our YouTube channel and you can watch other sessions as well and do this same process. You go to the course professionals page, you sign up for the course, you view a recorded session. This session will probably be up in the next 24, 48 hours. Maybe a week max if there's technical difficulties with that. And you sign up for that course, and then there's a little take the quiz button. It's 10 questions. Sometimes there's true, false, sometimes there's multiple choice or single choice. We try to make them not as complicated or hard. If you watched the session and you took some notes and you paid attention, it should be a breeze for you. You only need a 70% or higher. So out of the 10 questions, you can get 3 wrong. It is open indefinitely. So if you don't have time today to take the quiz, you can always take the quiz tomorrow or next week or next year. If you have any technical problems, you can also reach out to us at info@prehealthshadowing.com, and we are happy to work with you on if your time froze or your page crashed or whatever it is. And then there is sometimes a banner at the top. Make sure you exit out of any banners that come up on the page and click finish this course at the top, and you'll be sent to your certificate download page, or maybe the certificate will automatically download. It's been a while since I've taken one of these, so you can look into that. But make sure you click finish the course. A lot of people have that trouble. So if you missed any part of this session, say you fell off or your internet was crazy or whatever it is, we do have a YouTube channel. It's Pre-Health Shadowing. You can go on there. You can watch any of the videos from our past sessions. So if you don't want to go into pediatrics and you want to go into some other form of healthcare, then you can also go and see other professionals. There's PhDs, there's MDs, there's some MAs even in the pre-health world or the health world in general that have spoken and that have given their day to day or their wisdom. And so if you ever want to look into any of those, I know that the medical field is humongous. So if you're looking to see where you fit and what would be the perfect career for you, those are great opportunities to look into that. So make sure that you catch all of our sessions. I know we have a couple next week. We have a couple at the end of the month as well. If you go and you can actually register for all of those classes and you'll get notifications. You can also email us at info@prehealthshadowing.com, and we're happy to give you updates or remind you to come to these sessions. So be sure to do that, and see you next time. Thank you for joining. If you have any questions, feel free to stick around. You can ask me or any of the other students in the team, the volunteers. I'm also a volunteer, so if you have any questions regarding that, I am happy to answer any of those questions. Have a great one, and thank you so much, Dr. Whitaker, again, for all of that information that you provided us.
Yeah, of course. Good luck, everybody. Take care.